All right, guys, welcome to this month's presentation for our Reese series. Dr. Karen Muschler, toxicologist, going to talk about tox on the farm, and I will let her introduce herself. We'll get going. As usual, at the end, we will have a QR code that you then scan into your phone and fill out the appropriate paperwork, and you should get a CE certificate nearly immediately. All right. Thank you very much for coming, Doc, and I'll hand it over to you. I will be watching for questions in the chat. And if you have something, let me know, and we'll get it to Doc and we'll discuss it.
Thank you very much, Mr. Redquist. So I'm Dr. Karen Muschler. I'm an emergency medicine physician and brand new medical toxicologist. I graduated from fellowship here at Denver Health last week. And so I'm going to talk today about tox on the farm. And Dr. Farkas didn't give me any other parameters other than saying rural toxicology. So buckle up. I am, of course, speaking from a position of someone who grew up in a very suburban environment and have worked at primarily like tertiary plus care hospitals. And so I have some factual knowledge, but not actually all that much practical knowledge. So I would be very eager to hear at the end people's actual experiences with these sorts of environments and agrochemicals, industrial chemicals, and things like that, since I have not had that much personal experience from it. And if you see me looking down, I have a secondary screen with my actual notes on it, so I can see my notes while I'm lecturing for everyone today. So for our agenda, of course, we're talking about some veterinary meds and the human animal and how they don't always mix. Talk about some farm toxicology, some wilderness toxicology. And sadly, I don't have a lot of time today to really like deep dive into some of the really weird nerd things we can talk about with pesticides and rodenticides, plants, venoms, and stuff like that, even though I would be thrilled to do so. That is what I've done for the last 2 years, and I can't quite shove it all into an hour today. So we're going to talk about some of these rural hazards in toxicology. And fundamentally, there's a lot of the same hazards as it for city tox and some bonus fun stuff. But toxins and poisons don't care about your geography. So just because you're on a farm doesn't mean you can't overdose on your meds or drink a ethylene glycol, some antifreeze. That'd be the same as if someone drank it in the city. And so the location doesn't necessarily change all that much. The greatest hazards in these environments that are going to be your distance and time from healthcare. For some of these things like the antifreeze, it doesn't really matter as much, but for other things like methemoglobinemia, that's tremendously important and tremendously unfortunate when people are far from healthcare in those situations. So we're talking about some veterinary sources of medication issues and such like that to start with. So when it comes to veterinary meds, most veterinary meds are derived from human medications. So a lot of them are relatively similar, but a lot of those meds have then been redesigned, reformulated, and reformatted to be able to give to a creature who won't willingly take a pill necessarily. And so they're not necessarily still safe for human use in the veterinary form. There's a lot of different drugs available, same thing for human medicine. You have antibiotics, sedatives, antiparasitics, all kinds of different stuff. And so while they may mimic human drugs, their potency again is often higher because it's designed for sometimes a much, much larger animal. And though veterinary meds are not as common, chronic use and abuse of veterinary medicines is occasionally seen, especially when you start getting to overlaps of other categories of meds like opioids or other sedatives. So one of the issues when it comes to people using or playing with veterinary medicines is that the FDA does not mandate the same standards for vet meds that they do for human medicines. So while they are similar in their active compound, some of the other carrier agents and substances that are actually co-formulated, very literally formulated with the pill or the cream, may not actually be all that safe for human use. They're not tested for potency or purity in the same way that human meds are. And at the end of the day, even though we are pretty similar and most mammals are pretty similar, there's still fundamental differences. Take chocolate, for instance. Humans metabolize theobromine, the main alkaloid in chocolate, all day long. I did it before I started this lecture. Cats and dogs cannot metabolize theobromine at all, and it rapidly becomes terribly hepatotoxic and renal toxic to those animals. And so even though we're like mostly the same, we are still different at the end of the day. So for some fun meds, and this is basically what I said before, is even if the drug is the same, it's a different strength, it's a different route of administration. There's oftentimes other co-formulations that may not be safe for human use. They have different effects and different goals overall. And then in addition to all that, people are really bad at math a lot. And so when people are trying to calculate their dosage from a horse drug, they're not always so precise about it. So for some fun meds that I care about and that have been popularized recently and have some fun toxicology, we're talking about xylazine, telmicin, phenobarb, and ivermectin. And I actually took phenobarb out because it's not that exciting, actually. So talk about xylazine. Everybody's talking about xylazine all the time. It's a very trendy thing to talk about these days. Like it's some brand new thing that came out of nowhere, but it's been around for quite some time. There's been occasional misuse in animal husbandry, veterinary medicine, and farming circles for decades. It first popped into the like colloquial market in the 1980s as a contaminant in heroin in Puerto Rico. And there was a number of papers out from the late 80s, early 90s about patients overdosing on a combination of heroin and xylazine, much like we're seeing today with fentanyl and xylazine. As I'm sure everyone knows here, it has since spread across the United States as a contaminant or co-formulation, depending on your perspective, in fentanyl supplies, with Denver being relatively spared and other major cities being on the West Coast being more spared than the East Coast. Part of that is just drug routes and who gets what where. Um, Xylazine is a really fun drug, and by a fun drug, I mean it's a classic alpha-2 agonist like its cousins clonidine and guanfacine and dexmedetomidine, which is Precedex, and the latest and greatest fentanyl contaminant to hit the market in the last few weeks, which is medetomidine, a derivative of dexmedetomidine. And so these patients look all the same though, which is one of my favorite things about these drugs is that they all have different kinetic behaviors and properties and duration of action. But at the end of the day, our patients always are sedated, bradycardic, bradypneic, hypotensive with meiosis, which while it sounds an awful lot like an opioid, it's actually these alpha-2 effects. And they don't respond to naloxone, which is kind of one of the helpful clues. And the other helpful thing about some of our alpha-2s for things like clonidine and guanfacine, a little bit less potent than xylazine is, you like poke your patients and like mess with them and they wake right up. And that's very classic for these overdoses in general. Xylazine, because it is very non-specific at which receptors it acts on in humans, tends to be more potent overall, and so people don't necessarily wake up when stimulated. But for other alpha-2s like clonidine, like guanfacine, they wake up really easily. We see these a lot in kids. We manage these like if they're not waking up with an endotracheal tube, because a lot of times in tox, you just need supportive care, and an endotracheal tube is supportive care. And so throughout the presentation, I put these little green boxes for essentially what my pre-hospital recommendation summaries would be. And so for xylazine, it's if they're not breathing, you intubate them. And if their blood pressure is low, you start them on pressors. It's really straightforward. Patients generally do really well with these drugs. They don't tend to end up with a lot of harms overall. And there was actually a review published earlier this year for some like mass aggregate database research based on xylazine and fentanyl or fentanyl alone. And people actually had a survival benefit in xylazine and fentanyl groups, interestingly enough. So I'm going to move on to Micatil. And this is a macrolide antibiotic used primarily in cows and sheep. And it's given by an auto-injector, which of course invites potential for harm when misused or misapplied. And there was a big panic about telmicin in the early 90s because there was a couple of very dramatic, very rapid deaths. And it was thought to be because of very potent potassium channel inhibition, primarily affecting the heart in humans. Patients who got more than about a milliliter of solution injected into them, usually in the hand because they miss with a gun or, forearm, something like that. Patients died within a few hours of the exposure. In part, it was thought because adrenergic drugs, things like epinephrine and norepinephrine, which we would very commonly give for causes of cardiogenic shock and failure, were adversely worsening these patients' outcomes. And so the recommendation, should it be being used, is to avoid any adrenergic drugs in these exposures. That includes other like beta blockers, beta 2 agonists like albuterol, propranolol, labetalol, things like that. But more recent, again, like aggregate database research has shown that if you get under a milliliter injected into you, you're oftentimes completely fine. Thankfully, this has been a little bit phased out, and safety precautions around its use have increased pretty dramatically. So there have really been a paucity of cases over the last 20 or so years. But there for a while, it was a very hot topic in human medicine. There are a number of other antibiotics and antiparasitic drugs that we give to pretty much all animals that are not necessarily incredibly safe for humans. But one that we use in both, and that has, of course, been in the news much over the last 5 years, is ivermectin. Ivermectin had a lot of people using the horse dewormer during the COVID-19 pandemic. It is technically a human dewormer as well. We use it commonly with certain intestinal worm infections like ascariasis and strongyloides infections, as well as topically for rosacea in folks who have that skin disorder. And so while not unsafe in humans, people were taking it fairly chronically, thought to prevent or reduce the symptoms of COVID-19. And while that failed to pan out, we did get a rise in ivermectin overdoses. That being said, all things considered, ivermectin overdoses are fairly benign. Most of what we see is GI upset and some headaches and weird and non-specific neurologic symptoms. Oftentimes, these patients are being described as like off and goofy, and then in the worst cases, very sedate. I had a couple of these calls during fellowship, and most of the time it was just like, this dude is acting strange. Also, he's been taking ivermectin. And the good news is that these patients are almost universally totally fine with supportive care, and they don't usually need a lot of supportive care. The overdose tends to just present as they're being weird for days. And this is what we see in both humans and in animals when they're overdosed on ivermectin, is bizarre neurologic symptoms that last for day to a week and a half or more, and then they slowly resolve over time. Part of the really interesting chemistry for ivermectin is that ivermectin's chemical compound is very toxic to insect and invertebrate neurotransmission. So it inhibits 3 different binding sites on some of those, on the neurons of the insects and bugs and worms, that rapidly paralyzes and kills those bugs. We as mammals have certain protein compounds in our central nervous system that essentially pump ivermectin out of the central nervous system so that we don't get toxic at normal doses. However, when you overdose, you eventually supersede that system, and that's when you're getting kind of those bizarre neurologic effects. However, because the human neuron is different than the insect neuron, tends to not really affect us as dramatically, and we do pretty well overall with this. So if your patient is potentially overdosed on ivermectin, the recommendations are pretty simple. If it's benzos, if they need it, if they're wild and like out of control and it's needed for safety for you and for them during the ambulance or other transport ride. And if they're like too weird and altered, you can always intubate these patients. And I never besmirch somebody for intubating someone if needed. So I skipped over phenobarbital because honestly, phenobarbital is pretty boring. People are very, very, very sedated for a very long time. We use phenobarbital for epilepsy in animals quite often, and other types of seizure disorders. We use it in humans occasionally for the same thing these days, but we have more better antiepileptics for humans. Phenobarb, again, like it just makes you sleep for a very long time. Its half-life is something like 100 hours, so it just tends to be very persistent. So because I have not that much time and other interesting subjects, I wanted to move on to old things found in barns, which is perhaps one of the most terrifying phrases I've heard as a fellow, because there is a impressive variety of incredibly toxic compounds that you can find in like somebody's old barn. While I can't dive into every one of these, some general idea of what are found, things like malathion and parathion, which are old school organophosphate insecticides and pesticides that are still occasionally used with special licensing. Paraquat and diquat, again, herbicides that are remarkably toxic to humans. thankfully, again, very limited in their use in the modern era, but can still be present around in like people's barns and stuff like that from a time when it wasn't so limited. Chlorpyrifos, which is another modern and still nasty pesticide that is an organophosphate. Glyphosate, which is Roundup. And then literally of hundreds of thousands of more of these chemical compounds, each with unique chemistries and not always with robust human experimental data to say what actually happens to folks. A lot of these meds and drugs, while they fall into a one broad category, their individual chemistry is very different and is very important to consider when assessing toxicity to the human. Chlorpyrifos, which is an organophosphate, which we will talk about a little bit in the next slide, is a compound that's available as a granular substance. And my colleague actually had a case where someone tried to overdose on chlorpyrifos thinking it would kill him. But the problem is that chlorpyrifos is very insoluble in water. So he tried to eat it and couldn't really get it down, and it didn't dissolve in his stomach. And so he vomited a bunch and essentially had almost zero toxicity because he just didn't know how to manipulate the chemistry appropriately. Had he mixed it in like soybean oil before taking it, it would have been a very different story. But because of chemistry, his case really wasn't that bad overall. There's a tremendous number of automotive products out there that fall into all, again, like a variety of different toxicity groups and types. We have things like ethylene glycol, which is antifreeze, one of those toxic alcohols that we talk about all the time in my field. Methanol, which is your windshield wiper cleaner, as well as present as a carrier compound and a number of other substances that again falls in that toxic alcohol grouping. Toxic alcohols, since I'm not going to talk about them further, are alcohols that we ingest that are metabolized in the same biochemical pathways that we metabolize ethanol, which drinking alcohol, but their byproducts are damaging to the human body. So ethylene glycol is predominantly nephrotoxic and can cause pretty permanent renal injury and death secondary to that. And then methanol becomes very retinal toxic, so kills your vision, in addition to some other metabolic shenanigans in the process when consumed by the human. Hydrofluoric acid is a classic and terrible compound, which we will talk about some more. And then there's all kinds of proprietary lubricants for machinery and automotive parts and glues and other adherent substances that all, again, have unique chemical compounds and not always well studied in humans. They're also not always the same as other things. For things like glue, there are things that are like ethylene glycol ketones and other products that are used as part of the solvents in glue products that don't have the same chemistry as things like ethylene glycol, even though the words are awfully similar. Then there's the rodenticides. I know I'm very enthusiastic about a lot of things in talks and the horrible ways we kill things, but rodenticides really are the next level when it comes to attempting to manipulate chemistry to cause harm to a mammal, because we really have gone above and beyond when it comes to that category. There's a lot of different ways and chemical methods by which we have tried to reduce pests and rodents, and we will dive into those very briefly. And then there's the fumigants. Fumigants being chemical compounds that are usually solids that are mixed into other substances, things like grain, seeds, silage, to secondarily sterilize or reduce the pest burden in the big pile of organic matter that it is. Fumigants, again, are a surprisingly toxic group of compounds that are not always that well controlled. So we're talking about phosphines and phosphides, which are probably the most alarming of the readily available, if not as available in the United States as they are in other countries. Cyanides are also used for this purpose, again, to like kill the other organic matter or living creatures in the organic matter. Methyl bromide has been largely taken out, except for fumigation purposes for grain. It used to be used in old school fire extinguishers and as a structural fumigant for bugs and insects, but it's rather toxic to the human being. It causes a lot of different neuro and hemotoxicity effects that didn't go well when used as structural fumigants. So we're talking about the organophosphates. Organophosphates, I know them, I love them. They're one of my favorite compounds in toxicology because they are nasty but predictable. So these organophosphate pesticides have the same mechanism of action as nerve agents, so things like sarin, tabin, soman gases. And that is seen in that slightly disgusting picture on the left-hand side, which is describing that cholinergic toxidrome. And this happens because these compounds will be involved in a chemical reaction in a very specific part of the acetylcholinesterase enzyme in that neuromuscular junction. Acetylcholinesterase is responsible for turning off that neurotransmission at the muscular junction and at other parts in the autonomic nervous system throughout the body. When the enzyme is blocked, it can't turn it off. And so you end up with this cholinergic toxidrome of essentially overstimulation of that system. That reaction of turning that enzyme off is what we call aging. And that rate of aging, the rate of which that reaction happens, helps determine the badness of these overall compounds. Things like soman age in a number of minutes. So in a number of minutes, you cannot regenerate any acetylcholinesterase in the human organism, and you end up profoundly ill and in theory dying from it. Luckily, we don't have that many human cases throughout history, but we have a couple. There are other compounds like carbamates, which are drugs like physostigmine, pyridostigmine, neostigmine, and a couple of other compounds used to manage Alzheimer's disease and Parkinson's disease that do not undergo that aging reaction. So while you can overdose on those meds and you'll look the same as this disgusting picture, we can treat it more easily because the enzyme is recoverable, essentially. So what happens when you are cholinergic is you are basically wet all over and disgusting, and your heart is not working because it's too slow. So you end up having tons of lacrimation and salivation and vomiting and diarrhea, and you're sweaty, and you're usually incontinent of urine. The problem is that you are bradycardic and you have really bad bronchorrhea, so lung and upper airway secretions, and bronchospasm. So you can't breathe and you're drowning and your heart is too slow. And that combination, which is oftentimes referred to as the killer bees, is what leads to death and badness in these folks. We manage this with atropine. Atropine works to resolve the muscarinic peripheral symptoms seen in a cholinergic toxidrome. And oftentimes when it comes to the pesticide organophosphates, we need many, many milligrams, double-digit plus milligrams of atropine to try and manage these folks. And I'm sure you're thinking, I don't have that much in my rig. And that is correct. I also don't have that much in the emergency department, which is oftentimes where we get into trouble with these patients. We repeat the dosing pretty often, and essentially you are going to increase that atropine dose until the bradycardia and the bronchorrhea is improving. So you're trying to make sure they're not dying acutely. They can still poop themselves all they want, but as long as their heart is beating, that is what I need first and foremost. Depending on who you are, where you are, and what you're doing, sometimes there's also an agent called pralidoxime or 2-PAM available as well. In the military, we have this available as an auto injector with atropine pre-formulated. It's available in chem packs as well if you're into that disaster response and civil support sort of thing. That agent is thought to help reduce that rate of aging reaction. There's some debate about how effective it actually is in managing these patients. So my concern for trying to do the most important things for folks up front is to make sure we get atropine in them first and foremost, and then we can think about the other things. So sometimes these folks need to be intubated again, because again, there's just so much snot and secretions and things like that. And so that is fine if they need to be intubated, but atropine, 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 and then some more atropine. There's more fun with pesticides, and these are the organochlorines. These have been largely phased out in the United States, again, due to their relatively impressive, if slower toxicity. And the organochlorines all cause essentially nasty neurologic effects over time. These were chemicals like capone, lindane, DDT, classically, for those who are Silent Spring fans, dieldrin, aldrin, and they didn't cause that much acute harm for folks. The big problem with the organochlorines is that chronic exposure over years to decades leads to really nasty and irreversible neurotoxicity, usually of motor neurons in the spinal cord. So essentially, these are folks who would have severe tremors, basically unable to work because of how bad their motor response was, and they're basically unable to do things, essentially. Their use has been pretty dramatically limited in the United States, but are sometimes still available internationally. And so the PPE for this sort, or the pre-hospital recommendations for these things, like so much of what I'm going to talk about, is going to be protect yourself. And if they're seizing, you get benzos and you intubate them as needed. A lot of these pesticides were used for things like ticks, which is why there's that disgusting amblyomma tick up there, excuse me, Ixodes tick in the upper right-hand corner. For those of us who've ever spent time in the eastern portion of this country, have had lots and lots of those crawling us, and it's not my favorite thing. Talk about thiram very briefly. This is a very interesting chemical compound, again, that has been widely used in a number of different applications for fungicide, insecticide, disinfectant, and fumigation of seeds, animal repellents. That overall human exposures are uncommon, and we don't have a lot of robust data, but we do know that if you keep rubbing it on yourself as if you're a farm worker, golf courses and other places is used pretty commonly. You can end up with a number of effects over time, usually manifesting as hepatotoxicity, causes nasty dermal lesions. It can be neurotoxic over time. It's genotoxic, so it can have problems in offspring and reproductive issues after chronic exposure to thiram. And then it also causes something called a disulfiram-like reaction. And disulfiram is a chemical also known as antabuse that is sometimes used to try and treat alcohol use in people by essentially negative feedback. In the presence of disulfiram, you cannot metabolize alcohol beyond the making the aldehyde stage. And the aldehyde stage is where you get all of the unpleasant effects like flushing and headache and high blood pressure, and you just feel gross. Some people who don't have that much of the secondary enzyme of metabolism, aldehyde dehydrogenase, get those symptoms often in the presence of alcohol. Though I don't want to continue to stereotype, the Asian flush in presence of alcohol consumption is thought to be because of generally reduced aldehyde or alcohol, excuse me, acetaldehyde dehydrogenase in Southeast Asian populations. Some white folks like myself don't do it great either and get very hot and flush when we drink. And so to come full circle, this chemical compound will cause that same reaction in people who are exposed to it. And so as you can imagine, that's a negative effect for many folks. I apparently did not update my pre-hospital recommendations on that slide. I am so sorry. The treatment for these folks would be just supportive care. There's not enough exposure to pre-hospital to be able to say definitively what to do for them, and it's unlikely to be an emergent presentation most of the time. However, full hydrofluoric acid is an incredibly emergent presentation. Hydrofluoric acid is present in rust removers, brake cleaners, glass etching solutions, and in a couple of other places in around the home and workplace. These chemicals are varied in what percentage of hydrofluoric acid is included in the bottle. Most commercially available products are going to be under 40%, but in some industrial applications, you can get up to 100% hydrofluoric acid. And a 2.5% body surface area exposure of 100% hydrofluoric acid can be fatal. And the problem is that when exposed to the human body, the fluoride ion and the hydrogen ion rapidly dissociate, and fluoride is incredibly electronegative and will pretty much absorb all of the cations in your body. Things like calcium and magnesium in particular, it will suck it all up. And then with no calcium floating around, you can't do things like heartbeat good. And so we see this in folks occasionally, thankfully not that often, where an exposure to this will make them profoundly hypocalcemic. And even little exposures are usually incredibly unpleasant and painful, as you can see in this man's hand on the right-hand side of the screen there. That discoloration in his skin is the fluoride and calcium precipitating out of his bloodstream into the exposed area. As you can imagine, this is oftentimes incredibly painful, and most of the treatment focuses on getting more calcium into these people. And that's by two methods. One is if things are going poorly, intravenous calcium, calcium gluconate, as much as you have essentially is going to be the answer. But then we also try to apply calcium locally as well. So in smaller exposures, that means topical calcium, whether in a calcium gluconate gel or in a pinch calcium carbonates of Tums tablets, smooshed up in a lot of like sterile lubricant can help to just get it into the skin and try and reduce some of that bodily calcium absorption. In a pinch, you can give a person a bunch of Tums to chew, or if they've had an oral ingestion, we occasionally can recommend a little bit of oral Tums. However, unfortunately, inhalational exposures to hydrofluoric acid or intentional hydrofluoric acid ingestions are oftentimes quite fatal. This reaction is happening almost instantaneously, and so people are very ill very quickly when it comes to this compound. Lower home concentrations, things like glass etch solution, which are around 20%, are going to be uncomfortable, but not necessarily that bad off. But again, some of the higher concentration exposures can be profoundly negative from an outcomes perspective. Rodenticides. I'm excited to talk about this group because, wow, what a variety of horrible ways to die. Rodenticides have obviously been used throughout history trying to reduce pest populations. And one of the big problems with rodenticides is bioaccumulation and biopersistence. So while it might make the mouse sick, it's also going to make owls sick and larger predators and any other mammal that comes to snack on these things, essentially, or snacks on a rodent that has eaten these things, can get sick as well. So that's part of where a lot of animal activism and trying to reduce the toxicity of these compounds is coming from. So some of these more shocking ones are not very commonly available in the United States. Some of them are what we're using, even though we're trying to move to less toxic things. So essentially each of the bullet points here is a different grouping of rodenticides, of which there are many, many subtypes. And so when people call me about these sorts of things, my first thing is quite literally going to Google and seeing which of the following categories it falls into. So one of the classic categories for rodenticides is brodifacoums. These are superwarfarins. Also, the more modern one is the indandiones group of these compounds. And these all act essentially just like warfarin. But unlike warfarin, it's not metabolized in about 24 hours, and it can persist and really wreck that intrinsic coagulation cascade in the human organism, and really the other mammals as well. And so when they can't coagulate at all and you can't stop the bleeding, you end up bleeding out. And so this is both what it is intended to do in the rodent, is as it is going about its little mousy life, running around things, squishing through small corners, it gets crushed and has internal hemorrhage as the way to control the population. But unfortunately, this extends up the food chain as well to owls and other organisms we're not necessarily meaning to target. It does essentially the same thing in humans, which is to say that if you ingest some brodifacoum or indandione, you're going to end up with a very, very, very high INR that will take quite a bit of time to treat and manage. We manage it the same as a warfarin exposure, where we give vitamin K, we keep checking INRs over time, and we wait for things to normalize. Patients can need vitamin K, though, for months in these instances. When it comes to bleeding toxins, when it comes to anticoagulant toxins in humans, generally the secondary systemic effects are pretty limited. So as long as we keep the blood where it's supposed to be, we tend to not have a lot of problems from it. But obviously, if you're gonna bleed, if you have an INR that's, many double digits, that risk of spontaneous bleeding or bleeding after minor injury is quite high. Talk about the metal phosphides on another slide, so I will save that for now. Talk about hypercalcemia. We have high dose vitamin Ds. Essentially, the short version of it is that rodents don't handle vitamin D the same way that we do, and we can make them incredibly hypercalcemic in the presence of high dose vitamin D. These are overall thought to be less toxic to higher mammals, but there have still been cases of people getting into trouble with vitamin D based rodenticides. Is they're the same formulation that we use when we're treating people for low D, so cholecalciferol, tocilcalciferol, ergocalciferol, those other ones. But essentially, because mice don't handle it as well, it's toxic to them. Then there's a couple of older school rodenticides, again, thankfully not being used as much: bromethylene, dinitrophenol, and then SMFA. Bromethylene is a very neurotoxic compound that also poisons the electron transport chain, very similarly to dinitrophenol. When you have a poisoned electron transport chain, that means you are essentially not able to generate any ATP, and so you have no energy. And that very quickly becomes a profound metabolic acidosis and death. We see the same sort of behavior from things like really high dose aspirin or from cyanides, things like that. And so that inability to generate energy, as you can imagine, very quickly leads to problems. SMFA and fluoroacetamide is similar in the sense that it causes very rapid death from an inability to generate energy. But this works higher up than in the electron transport chain. This is actually, SMFA is an absolute inhibitor of the Krebs cycle. So for those of you that took biochemistry like I did a bunch of time and flashing back to a big circle diagram with all those enzymes, it blocks aconitase, and it blocks aconitase absolutely. So it cannot move any further down that chain. So it cannot make any ATP, you cannot make any reducing cofactors, and it ends up being quite bad quite fast. SMFA was used for a long time as a wolf poison. Basically, sheep would be baited with it, and then a wolf would attack the sheep and get a mouthful of SMFA. It would die from that. And while one sheep was sacrificed, the rest of the herd was safer, presumably. This has been up and down regulated a couple of times in the country in the last 100 years or so for its relative safety and risk to other people. Fluoroacetamide is a similar compound that's slightly different, blocks the same enzyme and does the same effect overall. Then we have chemicals like tetramine, which cause seizures pretty rapidly in both mice and humans. And then the old-fashioned strychnine, as we can see in that upper right-hand corner there. Technically, that painting is of tetanus exposure and not strychnine, but strychnine and tetanus toxin have very similar mechanisms of action. The actual chemical of strychnine will get into your neurons and block your ability to turn them off, essentially. We see the effects primarily in those motor neurons from the spinal cord. And what we see is essentially you're spasming to death, which, yes, sounds quite horrible. But you're unable to stop the neurotransmission from your central nervous system. And so you're basically just firing for your muscles to squeeze more and more and more and more. We end up with that sort of like body arcing position and posture because the posterior muscle column is overall a little bit stronger than the anterior muscle column. So things like hamstrings, glutes, the long muscles of the spine are a little bigger and stronger. So you get that upward contraction of the human body. People end up dying from diaphragmatic paralysis because the diaphragm can't relax. And so you can't take another breath. And as you can imagine, that seems like a very remarkably unpleasant way to go. Tetanus is similar in its mechanism, slightly different route by which it causes it, and slower acting than strychnine is. But as you can imagine, both remarkably unpleasant over time. Thallium, which old school horrible heavy metal poisoning that's associated with hair loss and very, very, very painful peripheral neuropathy. We still see this occasionally. It pops up every so often. There's been a couple of famous cases of attempted homicide from declined romantic advances and other routes. People poison things like candy, whether intentionally or unintentionally sometimes, and can lead to toxicity fairly quickly in the human. Older school rodenticide is something called Vacor or PNU, which is pyuranon, and then it's got a much, much longer name, which I honestly don't even remember. This will poison your beta islet cells of your pancreas, and so you no longer produce insulin, and so you end up diabetic. We treat this with B vitamins and obviously insulin as needed. And so as you can see here, the rodenticide group is dramatic and varied in its ways to kill small mammals. And so as you can see over there on the side, it's pretty much symptomatic and supportive care for the specific agents. So if they're seizing, give them benzos. If they've been exposed to things like brodifacoums, don't bump them too hard. We will talk about phosphides in a moment. Fluids and supportive care for vitamin D, high dose vitamin D, and if they're hypoglycemic, give them sugar. So I promise more about phosphines because phosphines are horribly toxic, and I do love a good horribly toxic compound. These are remarkably unregulated in other countries, and so while there are better controls in the United States for their sale and distribution and use, in some places you can literally just like go to the store and buy some. These are very unstable metal hydride compounds, metal phosphohydride compounds, where essentially you've got a metal ion that is complex to this phosphorus group. And when exposed to water and acids, it rapidly decomposes. So you get a metal ion, and then you get phosphine when the phosphorus binds up all of that hydrogen. Phosphine is a gas, and it is an incredibly toxic gas. It is classically described as having a garlicky or fishy odor, and it accumulates in low-lying areas. It is very toxic to mammals, and it is quite flammable, as if it wasn't enough fun for all those other things. When we get phosphine in us, it causes a twofer of terribleness in that it is both a metabolic poison, like the other dinitrophenol and bromethanol and the things we just talked about, and all the other electron transport chain uncouplers. And if that wasn't enough fun, it is also a direct oxidative stress. So we end up seeing clinically a lot of terrible things very quickly. Death could be within a few hours from these exposures, and it's from multitude of effects all at once. So you get hemolysis, methemoglobinemia, metabolic acidosis. You get pretty bad pulmonary edema from it, where it directly is causing that sort of irritant and toxic effect in the lung tissue, which also phosphorus will absorb your calcium, so you get hypocalcemic as well, and then you die. Because of the hemolytic stress, really the only pre-hospital intervention that you could probably do would be blood products, but it would be hard pressed to use that and give that up. But it would be like the one thing I could think of doing pre-hospital to help with these. However, PPE is going to be critically important for these because you can get very sick from it as well. Like any sort of enclosed space with a nasty gas can accumulate. And so that's where we tend to see harm for folks. There have been a couple of cases of this like being in people's barns. I had a call a couple months ago where it's just like some lady found a bunch of jugs of it, or a bunch of like canisters of this in an old barn. And so it's still around. That obviously can be a problem if it gets wet in any way. And there's been a couple of cases of very sad outcomes for people not knowing it was around and it rained, or like putting it in the basement and not knowing that the humidity of the basement would cause phosphine gas to be released over time. And so this one can be quite problematic. That wasn't enough fun. We're going to talk about some other terrible ways to go that are related to the farm. So we're going to talk about manure pits, which I appreciate the creation and production of fertilizers and what it has done for agriculture. However, manure pits are surprisingly toxic. There's a lot of fun and terrible gases that are produced when the decomposition of organic matter. And it's also a surprisingly common way to still have death and harm to folks. So when manure pits, and by extension, any other area where there is a lot of organic matter decomposing in a confined or enclosed space. So in theory, you could have a cave with a lot of dead organisms, dead plants, and cause the same thing. We see some of the same compounds in mining, where you've got this accumulation of gases in these low-lying, relatively enclosed areas. But there's a variety of stuff that gets made. Things like ammonia, hydrogen sulfide, methane, carbon monoxide, carbon dioxide, bacterial endotoxins. All of these together are relatively heavier than air, and so they accumulate in these low-lying spaces. And when you have an enclosed manure pit that is not being appropriately ventilated, all of those fun gases there can cause very rapid collapse in humans. When it comes to something like a manure pit, we don't know which one specifically will cause the collapse, because hydrogen sulfide will cause a knockdown effect. Methane is a simple asphyxiant and can cause a knockdown effect. Carbon dioxide is also a simple asphyxiant that can just knock you out with a high enough concentration in the air. And so the problem what we see is that, one person goes down to check out the pit and then doesn't come back up. And then the next person goes looking after them. And with these really high gas concentrations in the air, people just are, it sounds so simple, but that's literally what it is. They're just knocked out. Hydrogen sulfide is very classic and famous for this, because we can detect hydrogen sulfide very, very well at very low concentrations. The human olfactory response to hydrogen sulfide is sensitive to like a half a part per million. So we smell that funky, nasty, rotten egg smell that low. But when we start to exceed 100 parts per million, we no longer detect it. It actually paralyzes the olfactory nerve, and we can't detect hydrogen sulfide anymore. At concentrations over about 1,000 parts per million, that is where we are immediately unconscious. We don't fully understand why this happens. We do know that hydrogen sulfide is very lipophilic. It rapidly penetrates the blood-brain barrier. It attacks the electron transport chain in ways similar to cyanide, but doesn't have the same binding that cyanide does. And so like people just they're just down. There's no other way to describe it other than being just down. For our simple asphyxiants like methane and carbon monoxide, or excuse me, carbon dioxide, it's sort of similar. There's no oxygen in your atmosphere. You breathe a couple times, and then that lower oxygen concentration triggers you to breathe more, and then you breathe more rapidly, and then you're unconscious because there's no oxygen. This is still quite fatal. Between 1975 and 2021, there were 486 incidents, with 288 of those being fatalities from people like wandering into the manure pit. So there's a lot of activism and safety around trying to have these places better ventilated and better secured, so like other people can't wander into them, and then just trying to ventilate to make those gases go away. As I'm sure you read in the time I was talking, these are also flammable, especially if there's a lot of methane around and ammonia. And so be careful with the flames. As we talked about before, you too can be affected by the manure pit if you do not PPE yourself. And this unfortunately is going to be gas, PAPR, or SCBA prevention of you inhaling those gases. Hydrogen sulfide is a teeny tiny molecule, and so will penetrate anything less complicated than an SCBA. Because I love a good meme. Brother, ew, manure pits are not into it. Speaking of ammonia, anhydrous ammonia and other ammoniated compounds are yet another interesting thing in tox. I know I keep saying it a lot, but I do love the subject so much. Anhydrous ammonia, we've all smelt it. Maybe played with some of the hydrated ammonias when we've had like ammonia cleaning compounds in the home, but ammonia causes burns. It's interesting in that it doesn't cause a lot of other toxicity. It just burns the absolute bejesus out of whatever it touches. And importantly for us, that means eyes and lungs. As that gas increases in concentration, it can burn the corneas quite badly, and it burns the lungs, which then causes things like pulmonary edema and ARDS. There's not a lot of other like magical antidote for ammonia. It's going to be copious irrigation, so all the water you can get in someone's eyes if they've been exposed to a lot of ammonia, the solution to pollution is dilution, so lots and lots and lots and lots and lots and lots and lots, and then some more irrigation, and then if the lungs are bad enough, people need to be intubated. And so since we've talked about breaking your lungs with anhydrous ammonia, we're going to talk about some other horrible ways in which farming can harm your lungs. So there's a classic one, silo filler's lung. This is from nitrogen dioxide, which is classically a reddish, rusty color. And this happens when essentially fresh silage is dumped into a silo and then someone opens the silo and you get a big blast of this gas in your face. Nitrogen dioxide itself is very irritating to the lungs, so you get pretty rapid ARDS. It can also act similar to the other dioxides I've talked about already and cause that kind of rapid knockdown effect. It also, if that wasn't enough fun, causes metabolic acidosis and other electron transport chain disruption, as well as rapidly reacting with water in various environments to become nitrous acid and a couple of other nasty compounds. Farmer's lung is different. Farmer's lung is a hypersensitivity pneumonitis thought to be most commonly to actinomyces species, again, found in like naturally occurring in hay and silage. This is not technically a toxin, but because the names are similar, I put it in here for clarification. But this is essentially you develop an allergy to your products, to your farming. And so this is kind of the thing where like the farmer goes to work, gets exposed to this allergen, develops a hypersensitivity syndrome. So this can be something like an anaphylactic like syndrome, or it can be a systemic immunoresponse like a SIRS-like response, kind of sepsis, where they're tachycardic, tachypnic, febrile, short of breath, and feeling quite unwell from that perspective. Once they get removed from the environment and treated, they get better. But if they go back to it and keep re-exposing themselves to the allergen, they keep getting sicker and sicker. And then from like a fun trivia perspective, there's something called byssinosis, which is a pneumoconiosis of cotton working. So the same thing if you flash back to your Date Myself Zoolander days, where he's got the black lung pop. Black lung is coal pneumoconiosis. This is cotton fibers. And it's essentially those teeny tiny chronic exposure to like micron-sized bits of cotton that cause a chronic fibrotic lung disease. Same thing as coal mining, same thing as other heavy metals and silica mining and silica exposure, but cotton bits instead of iron bits or tin bits. For when it comes to these lung diseases, there's not a lot special to do pre-hospital other than if they're hypoxic, you give them oxygen, and if it's really bad, you intubate them. If someone has a hypersensitivity like picture where they're short of breath, maybe they're a little rashy, they look allergic. So this is someone I could consider giving steroids and albuterol to, but it would be a case-by-case basis for how to treat and manage these folks. But there's more rural than just farming. So a little bit about poisons in the wilderness, and sadly, again, I can't spend tons and tons of time on the natural world toxins. That is my particular favorite subject. But for like other things where people can be far away from healthcare, if you've got a well-sealed tent, you can give yourself carbon monoxide poisoning from bringing your burning propane or kerosene tank or jet boil or whatever inside your little room. I had a couple of cases similar to that where people were in a tent essentially and had that stuff burning and ended up feeling quite poorly. If you forage poorly for your wild plants and mushrooms, that can end up very bad. I'm not going to talk about mushrooms today because that is, again, its own whole thing, but I'm going to talk about a couple of plants that are fun in a moment. And those toxic plants, there's the toxicodendron family. So that's your poison sumac, your poison oak, your poison ivy. All of them have a chemical called urushiol in the leaves and like on the presence of the surface of their berries and leaves. And that urushiol is very irritating to human skin, as I'm sure many of us have personally experienced before. That irritation becomes a hypersensitivity response. So the more times you're exposed to it, if you have developed an immune reaction to it, you end up with horrible itchy rashes all over your body. And if you've experienced it once, you know what I'm talking about. It is not a good day. While maybe not an emergency, it is certainly quite unpleasant. In a similar vein of horrible things coming out of trees, there is a tree in rural and remote parts of Florida and the Caribbean called manchineel, which I'll get into in just a moment. And then, of course, there's my most favorite category of dangerous animals, snakes, spiders, scorpions, and I'll have a couple of words on some marine animals, because technically you can be isolated in the marine environment. Thankfully, most of our marine critters are pretty benign in this side of the world. That statement does not hold true if you're in Australia, Bay of Thailand, Southeast Asia, but marine animals in and around the United States waters are pretty benign. We treat most of it with just hot water immersion, where it's literally putting the affected body part in a vat of hot water at about 45 degrees Celsius, because it is thought that the hot water will neutralize the toxins. And it honestly does seem to work as well or better as a lot of our other more complicated interventions. So it's really where we're going these days with most of our marine creatures. That being said, stingrays, sea urchins, and lionfish are all thought to be toxic by like people at large, but really there's very weak evidence for any significant toxicity, and their problem is not so much a poison or a toxin or a venom as it is trauma. And so for things like stingray barbs, those are really hard. They can be up to like 4 to 5 inches long, depending on how big the stingray is. R.I.P. Steve Irwin, if they hit you hard enough, it can penetrate the thoracoabdominal cavity. Steve Irwin is one of 8 people to have died from thoracoabdominal trauma from a stingray barb hitting a, unfortunately, very sensitive spot. So we're talking about some of our plants here. I'm talking about manchineel first and foremost. This is also known as the death apple or beach apple of death, depending on who you are and where you are. It is in the euphorbia family of plants, which, if you're a plant nerd, euphorbias are known for having highly irritating and dermatotoxic compounds in the latex or the sap of these trees. Manchineel is famous because it produces so much of these compounds that if you happen to stand under the tree while it's raining, that water washing over the tree and landing on you carries enough of those toxins to cause burns and dermal injury. The big problem is, of course, then that this burns any skin or soft tissue area. So if you are burning wood that happens to be from manchineel, you are making a very toxic dust cloud or smoke cloud, essentially. If you eat the fruit, it causes very profound burns of the mouth and the esophagus, secondary burns in the GI tract, which can lead to edema, fluid losses, and shock. These are largely removed from Florida for the most part. They're still present in certain parts of the Caribbean, though. Some other fun ones. These are all found in Colorado, unlike the manchineel. So we're going to talk briefly about death camas, poison hemlock, and water hemlock. There's actually been a couple of news articles this year because apparently there's a bumper crop of poison hemlock, which is a bad time for folks and Socrates, since that is what supposedly killed Socrates. And I actually had a call a couple weeks ago about maybe a kid in Montana ate some death camas. The problem with these three is that people mistake them for wild other plants. Death camas is often thought to be wild onion. The hemlocks are thought to be wild parsnip or wild carrots. And I am not sure why you wouldn't just go to King Supers and buy yourself 5 pounds of carrots if you really wanted a carrot that badly, but who am I to judge? And so these all have really different toxins. The death camas has something that's called a veratrum alkaloid. These are known to be sodium channel openers that essentially cause really bad dysrhythmias. We manage it with atropine or amiodarone, depending on who you are, where you are, and what it was. There's a couple of other cousins in that veratrum family, like rhododendron. Monkshood or wolfsbane also falls into that group. And because of its mechanism, we kind of adjust on the fly to what seems to be the bigger problem for the individual person if they're having too little sodium transmission or too much sodium transmission. Poison hemlock, again, this is the one that's particularly been noted to be quite widely seen in Colorado this year, is Conium maculatum. And that is a nicotinic toxin. It essentially acts on those neuromuscular receptors, like we've talked about so many times already, and causes paralysis of them. That is obviously a big issue because it's nicotinic. This tends to be all of our big muscle groups. So unlike the anticholinergic toxins, or excuse me, cholinergic toxins we talked about before, this affects the different receptors, which basically gives you a flaccid paralysis over time. Patients tend to start out tachycardic and then get progressively bradycardic, and then really weak from all that muscle weakness, and then eventually will die from a flaccid paralysis. And then there's the water hemlock, Cicuta maculata. This is different from poison hemlock, as you may have noticed by the fact that I have put 2 different ones up there. This one grows more in swampy areas, so a little bit less common in Colorado, and tends to be very stripy on the stem, which is why I picked this picture here. It's got those visible stripes. It contains a very different toxin called cyclotoxin that is a potent GABA inhibitor that leads to very refractory seizures. Again, we talked about kind of GABA and glycine inhibition. We talked about strychnine and tetanus, and any of that inability to turn the nervous system off leads to seizures and problems for folks. And because I couldn't get through a presentation without talking about snakes, I am sorry if you heard my lecture a couple weeks ago about snake bite and envenomations in the state. Some of these slides will strike you as quite familiar if you saw that one. But there are about 8,000 snake bites in the United States per year, leading to about 5 deaths, though that number varies dramatically year to year. There's a very seasonal distribution, it's a very regional distribution. And like all things venomous, the American version is kind of wimpy, honestly. Not all bites in envenomation, but about 25% of bites happen because you are messing with those snakes. So usually I don't want to say someone deserved it, but they certainly put themselves in a situation where it would be more likely to happen. From a pre-hospital perspective, this is the most important thing: is don't do anything to a snake bite victim. Don't put a tourniquet on, don't rub dirt on it, don't use a venom extractor found on Amazon, don't electrocute it, don't cut it out, don't get drunk, don't pee on it, don't suck out the venom, don't panic, just bring them to a hospital. These things are sold online. They are actively causing people harm. And so if you have it, throw it out. If you know somebody who has it, encourage them to throw it out. It will do nothing to change the venomation syndrome that they might have. It will only cause more skin and soft tissue injury. We have 3 venomous snakes in Colorado. We have the western Massasauga, the midget faded rattlesnake, and the prairie rattlesnake. The midget faded rattlesnake is kind of in the southwest corner. The Massasauga is in the northeast corner. The prairie rattlesnake is everywhere. And so for most people who are envenomated in Colorado, it's statistically going to be a prairie rattlesnake that causes the issue. Rattlesnake envenomation in Colorado is predominantly hemotoxic with a side of skin and soft tissue injury. Comparing this to Arizona, where we see tons and tons of bleeding from things like the western diamondback rattlesnake, or compared to Virginia and Maryland, where we have things like cottonmouths and copperheads that cause almost exclusively tissue injury. Our snakes kind of fall in the middle. We use Anavip and Crofab to treat. The individual drug is based more so on what that pharmacy stocked than any like preference for treatment or efficacy. And so getting folks to healthcare is really the most important thing in the setting of a snake bite. So don't panic. You have time in the United States. Just because you're bit, again, doesn't mean there was actually venom injected. That venom injection is under volitional control of the snake. And so not all bites mean there's venom. You can splint for comfort, and that's really the most important thing pre-hospital, is just if it's an arm, put it in a sling. If it's a leg, keeping it a little bit below the level of the heart and still during transportation. And then marking that time and the edge of swelling is important. That it will help me later on when they call me to help manage those snake bites, because the rate of time of which the swelling is increasing is one of the things I consider for treatment about how to give antivenom and when to give more antivenom. Part of the reason I include this snake on this slide is because it highlights an important factor of the bite, is that this guy only has one fang sitting in this glove. And a snake bite is classically thought of course, as two fangs. And most commonly, it probably is going to be two fangs, but it can be just one. It could be a side swipe strike where they get a cut and not a fang mark. It can just be the one fang. It can be a bunch of fang marks, depending on how angry the snake was. And so the appearance of the wound doesn't change anything for me. You can get venom in you with a side swipe cut, and you can get venom in you with a bunch of different poke holes. I have no way of telling how much venom the snake put in you. I essentially have to guess. That's why we dose antivenom so seemingly randomly. It's because I'm trying to match the antivenom to what the venom is, and I have to guess at what that is. So again, split for comfort, and then mark time and borders is very, very helpful. Every 30 minutes is my hope most of the time. I get varying compliance with that, but ideally every 30 minutes would be what I would hope for. Some examples of what horrifying snake bites can look like. The one on the far right obviously had a tourniquet on. It's got that nice, harsh, demarcated line, which has probably increased the soft tissue injury this guy is going to have. We don't tourniquet American snake bites because they are so soft tissue toxic. Other countries where sometimes tourniquets or something called a pressure immobilization bandage is recommended because they are much more neurotoxic. And the neurotoxicity, if we can prevent it spread centrally, can be helpful. Ours, it just makes the wounds worse for folks. This is a patient I had who got bitten down in Pueblo earlier this year. And this is honestly what the bites I have seen in person have looked like. You've got a wound. There's usually some evidence of localized hemorrhage and ecchymotic changes around the wound. This has had the borders kind of marked, but not timed. And if I'm remembering the case correctly, this was the max line, was that line up on his wrist there. And he got much better with 10 vials of Anavip and did not need a whole lot of other care. And then last but not least, for our bitey things, we're talking about Latrodectus. I am talking about Latrodectus, which is the widow spiders, and not about our recluse spiders, because one, we don't natively have recluse spiders in Colorado, and two, recluse bites should never need EMS. I will just end it there. They are a very slow evolving process that in most adults does not cause significant like systemic harm. And so they should not call 911 for their wound. But widow spiders, they reasonably could. So widow spiders are, as pictured there, we call that black widow, which is Latrodectus mactans. It's a common one that's present through a lot of the country, but thanks to global trade routes and climate shifts and other effects, we are seeing kind of big shifts in like what the spider milieu is in this country. We're seeing an increasing number of brown widow spiders, which look essentially the same, except they're not dark black, they're brown. And we're seeing some international species of widow show up every so often. The really fun thing about widow spiders, whether it's the Australian redback, which is Latrodectus hasselbacki, or if it's the Italian version, Latrodectus tristemigmatis, if it's our version, their actual protein toxin is all the same. It's a mammalian specific pore forming toxin that basically punches holes in your neurons and causes massive non-specific neurotransmitter release. This sounds terrible and it feels pretty bad when this happens to folks, because what that means is they're getting a big surge of epinephrine, acetylcholine, norepinephrine, and that leads to really big muscle cramping and hypertension and pain and weird patchy sweating. Classically, one of the descriptions you'll see localized piloerection, so your hair standing up, and sweating around the bite site. As other weird neurosymptoms like paresthesias that can be kind of like progressive from the bite site itself, oropharyngeal numbness and tingling. Usually, this evolves over hours. Oftentimes, I had a great case last year where a woman woke up at 2 a.m. because her hand was tingling really badly. She fell back asleep. She woke up at 5 a.m. and her whole arm was tingling. She came into the hospital by about 8 a.m. and was having tingling all over, as well as her back hurt, her belly hurt, her legs were hurting. She had a headache. Her blood pressure was like 150 over 100. The doc was like, could this be a widow bite? And I was like, 1,000% that is a widow bite. So sometimes they cause some other really weird neurologic symptoms, particularly in kids. It can be hard to identify that a spider bite was the cause of the things we're seeing. But so it needs to be just like kept on that mental radar. Kids in particular can have a lot of belly pain with spider bites, which has sometimes led to unnecessary exploratory laparotomies for kiddos. And so it always needs to be on the differential. We have an antivenom for widow bites. It is actually really effective. And honestly, my decision to give the antivenom is if you've tried some pain meds and they're not better, then I give it. It does have some risks from immunologic effects because it is a whole protein compound in the venom, but most people are so miserable they're willing to take that risk to feel better. So there's more to worry about, of course, instead of everything I've just talked about, and manure pits, which, they're so gross. So one of my biggest concerns, one of the things that's most alarming to me, is that farming has the highest fatality rate by job in the United States. Most of the cause is traumatic injury, and tractor rollovers being that most common of the other ways to get it, but there's also fractures and amputations from farming equipment. In addition to that, in a study that was done in 2021, 70% of younger farmers, so farmers under the age of 60, met criteria for generalized anxiety disorder. And 53% of them met criteria for major depressive disorder. And so that combined with the worsening and variable opioid crisis, which of course affects everybody and not just folks in the city, has led to a big rise in overdoses for people who are remote farm workers and other such more disparate populations. Of course, there's no difference to treating the opioid overdose in rural Colorado versus Denver. The answer is naloxone and supportive care, and then more naloxone if we need it. But access is obviously a big issue. Limitations, people not knowing that somebody has an opioid use habit or can be all more negatively affect folks' outcomes. So that is what I've got for today. I'd love to discuss some other stuff, seeing if anyone has any firsthand experience. That is your QR code of choice, and that is my beloved cat who, since I'm moving today, is staying with his cat grandparents. So I saw some stuff pop up in the chat, but I am not facile enough to talk and look at the same time. So asbestos. Asbestosis is seen in any old insulation, of course. We see asbestosis, which is that pneumoconia, which is, yes, it's a pneumoconiosis from asbestos. But people fall into two groups. There are those who just have asbestosis, where they've got that chronic fibrotic lung change from asbestos fibers, which are really sharp microcrystalline fibers, obviously made of rock, and like what asbestos actually is. Great thermal insulation, bad for the health. We see mesothelioma when you've had decades of asbestos exposure and tobacco use on top of it. That's really where that like unfortunate sweet spot for terribleness was, is that two for effective lung injury from those two different routes, which led to the development of mesothelioma. Thankfully, we've largely gotten rid of asbestos, and so it is not as common as it once was. It's still around. But the issue with asbestos is not just like it's in your wall. As long as it's in your wall, it's not harming you. It's when you start pulling at it and like releasing those fibers where you get exposed. But again, decades and decades of exposure, not like you walked into the room where there's an asbestos in the wall. So I'm happy to field any other questions or discussion.
All right. Anybody having any trouble with the QR code? Yes. Phenomenal lecture. I love hearing your talk stuff. I'm a tox geek, glowworm on the fire department sort of guy, and it's cool.
I think so too, but
Yeah.
I'm biased. So, well, yeah. If no one else has any questions, that is my personal email. I am losing my Rocky Mountain email this week, so if you want to reach out to me, if you've got other questions, if you want to argue or debate, I am happy to field all of it. Be safe out there. Protect yourself before you wreck yourself. And thank you for what you do.
Thank you. Thank you very much. Thanks everybody for your attendance. We'll stay around a couple minutes to field questions. And if not, we'll end the lecture and see you next month.